To the people who don't know me, my name is Muntadher Khaleefah. I'm a PGY4 neurology resident, and my today presentation about the neurological manifestations with the COVID-19 infection. So I have nothing to disclose on my talk today. Most of the information here obtained from published studies and articles. So the learning objectives on my talk today, we'll learn about some of the proposed mechanisms on how the virus can reach the CNS or attack the nervous system. We'll also review the neurological symptoms and manifestations reported with the COVID-19 infection. And we'll discuss some of the long-term complications after COVID-19 infection. There is a recent study done last month. We'll discuss at the end of the presentation. And hopefully also we'll have a few minutes to answer questions and do a brief discussion after that. So I'll start my talk to give a brief introduction and background on the on the coronaviruses. So the coronavirus is a single-stranded enveloped virus that has the name the corona because it looks like a crown because of the S protein or the spike protein that the virus uses to attach to the functional receptor. The functional receptor of the virus is the ACE2 receptor, which is present in multiple tissues, including neurons and microglial cells. As the virus attaches to the surface of the cell, it will fuse with the cell membrane. Then the RNA will get into the cell, use the cell organelles to replicate itself, and then multiple copies of the virus will get out to infect other cells. So far, there has been 3 pandemics with the coronaviruses. The first pandemic happened in 2002-2003 in Foshan, China, and it's called SARS-CoV, which stands for Severe Acute Respiratory Syndrome caused by coronavirus. The second pandemic happened in 2012, which is the MERS-CoV, stands for Middle East Respiratory Syndrome caused by coronaviruses. This pandemic started in Jordan, then spread to the Gulf countries, then to India and the rest of the world. And the third one, we are still living, it's the COVID-19 that started in December 2019 in Wuhan, China, and then spread to the rest of the world. There are 2 genera of the coronaviruses, as we see here, the alpha, beta, gamma, and delta. And I highlighted the alpha and beta in red because they have the ability to transmit infections from animals to human. And that's what we think happened with the COVID-19 when it transmitted from bats to humans. On this slide, I'm showing you parts of the brain where the ACE2 receptor has been identified, which could be the target for the virus. And as we see here, brainstem, including medulla oblongata, it's a target, intraventricles, motor cortex, and the olfactory bulb. Also, the cerebellum is a target for the virus, but it's not highlighted here on this slide. So what are some of the routes that the virus can reach the CNS? So there are some theories about some routes that the virus can reach the CNS. One of them is the olfactory pathway. They think that the virus could retrogradely migrate through the olfactory nerve, olfactory bulb, olfactory tract, and reach the CNS. And there are some studies that support this idea. One study has been done on mice and showed that after resection of the olfactory bulb in mice, that would decrease the spread of the COVID-19 to the CNS. Another multi-center study has been done on 417 patients, showed that up to 85% of the patients had olfactory dysfunction, and about 12% of them, they do have the olfactory dysfunction even without having other COVID-19 symptoms or nasal congestion. That can also suggest the possibility of the virus infecting the olfactory cells and olfactory nerve and causing this symptom. Not just the olfactory nerve could be the route to the CNS, but they found that other cranial nerves could also be a potential cause, including the facial nerve, the trigeminal nerve, and the vagus nerve. And this could explain some of the symptoms with the COVID-19, including loss of taste of the coda tympani of the facial nerve involved, or GI symptoms with the vagus nerves, or even respiratory failure, as we already showed. The medulla oblongata could be a target for the virus where the respiratory center present. Hematogenous pathway, another pathway that the virus could reach the CNS. It was found that the ACE2 receptor also present on the endothelial cells of the blood vessels, including the blood vessels in the CNS, and with the presence of the inflammation and the cytokines that could increase the causes vasodilatation and increase permeability through blood-brain barrier and make the virus get entry to the CNS. Also, lymphatics could be a pathway. New studies showed that the lymphatic drainage does exist in the brain. And studies showed that the COVID-19 causes lymphocytic endotheliitis in multiple organs, including heart, kidney, and lung. So how does the virus causes the neurological symptoms? And the exact mechanism, the answer for this question is we don't know. But there are multiple theories, mostly taken from the prior pandemic with the SARS-CoV-1 and MERS-CoV. And there are theories for both direct invasion and indirect pathway that the virus could cause neurological symptoms. So mechanism by the direct damage of the virus, we already saw that multiple places in the brain has the receptor for the virus. And the study showed the ability of the virus to invade and reach the CNS. Also, multiple patients who had neurological symptoms, they were able to identify the virus in the CSF, which could also give some indication for that. This is a recently published study done on 33 patients post-mortem, and they took multiple samples from the brain, oral and nasal mucosa for the availability of the virus. And as we see here, there are like circles and triangles, and circles represent females, triangles represent males, and each color represents one patient. And we can see here multiple parts of the CNS they were able to find the virus, including the olfactory mucosa, olfactory bulb, trigeminal ganglion, medulla oblongata, and cerebellum. Hypoxia itself could be a way for causing CNS symptoms. As we all know, increasing anaerobic metabolism can result in lactic acid accumulation, which could cause vasodilatation, cerebral edema, and increasing intracranial hypertension, which could compress on blood vessels and precipitate ischemic symptoms in some patients. Another proposed mechanism is the immune damage to the CNS, either by a cytokine storm, which is a huge release of inflammatory markers during the acute illness with the COVID-19, where like interleukin 1, 6, tumor necrotic factor can affect not only target the virus, but will also target multiple organs and causes damage. One study found that interleukin-6 was possibly correlated with the COVID-19 symptoms. The distribution of the ACE2 receptor, the function receptor for the virus, throughout multiple organs could also predict some of the symptoms and the complications with the COVID-19. For example, the invasion of the endothelial cells in the blood vessels could result in blood pressure fluctuations, or could cause damage to the capillary vessels, which can result in strokes and intracranial bleeding. Arrhythmia could also be a potential cause, either directly by invasion of the virus to the heart, or secondary to the severity of the disease and hypoxia, and multi-organ dysfunction another way by causing hepatic or renal encephalopathy. So we talked about how the virus can get entry to the CNS and some of the potential mechanism of damage. Now, what's the neurological symptoms with the COVID-19? And since the start of the pandemic, scientists and doctors start to fear that this virus can also be associated with the neurological symptoms, since the prior pandemic with the coronaviruses in the past had been associated with the neurological symptoms, including viral meningitis, encephalitis, ADEM, GBS, and others. And since the pandemic started, multiple case reports, case studies, and cohort studies have proven that COVID-19 also associated with the neurological symptoms. This is one of the first studies that has been done in Wuhan, China at the beginning of the pandemic. It is a retrospective cohort study done on 214 patients, and they found that neurological manifestations was present in up to 37% of the patients. Most of the symptoms happen in elderly patients, those with severe COVID infection or with other comorbidities. Usually the symptoms tend to happen within 1 to 2 weeks from the initial COVID presentation, but sometimes patients could present with the neurological symptoms on the initial presentation. So the reported neurological symptoms with the COVID-19, as we see here on this diagram, it's not only central nervous system, but also peripheral nervous system and musculoskeletal and muscle injury can happen. The most commonly reported CNS symptoms are the headache, dizziness, altered mental status, and strokes. Whereas on the peripheral nervous system, the most commonly reported symptoms are the anosmia, dysgeusia, GBS, nerve pain, and muscle injury. So dizziness with the COVID-19, it is one of the early symptoms that happen with the COVID-19. Usually a common symptom with the infection. In the Wuhan study of the 214 patients, it was reported as number one or the most common symptom that happened up to 17% of the patients. Unfortunately, they were not clear why the dizziness happened, if it is vertigo versus lightheadedness, if it's related to viral prodrome or secondary to cerebralitis or strokes, ear infections, or others. Another study was trying to answer this question. It was done through literature search for articles to associate the dizziness with the COVID-19. They were able to find 14 studies, including 4 case reports and 10 case series. And as we see here on this slide, those studies has been done throughout the world in different parts, including United States, China, Turkey, Italy, and Canada. But still, unfortunately, the dizziness was not investigated in most of those studies. So only couple case reports have been investigated. One of them was found to have vestibular neuritis, then treated with steroids, meclizine, and the symptom resolved. The other one, it's also a case report, has been investigated with MRI brain, treated, but we don't know what's the outcome. So we still not sure why the dizziness happened and what is the reason for it, and further studies needed to clarify that. Headache is another common symptoms with the COVID-19. It's one of the early symptoms that happen with the infection. It was reported as the second most common neurological manifestation in the Wuhan study that happened in 13% of the patients. Another study done on 262 patients, they found that this study done on patients with pre-existing diagnosis of headache in the past, but they defined a new type headache associated with the COVID-19, usually happen at the same time with the COVID symptoms, including the anosmia and dysgeusia. So that made the authors of this study think that possibility of the headache is the trigeminal nerve ending invasion by the virus. Same thing, we still don't know the exact reason for the headache, if it's related to meningitis, viral prodrome, or other etiologies. Altered mental status with the COVID-19. Unlike the headache and the dizziness, usually it happens a little bit later, like 2 weeks after the infection, and most commonly happen in severely ill patients. And one study found that up to 69% of the patients who were admitted to the ICU with COVID, they have some sort of mental status changes. Usually the investigations with the MRI and EEG show non-specific abnormalities, which make us think that the possibility of altered mental status likely related to toxic metabolic encephalopathy and multi-organ dysfunction. Although some case reports have shown an acute necrotizing encephalitis to be the cause of altered mental status in a few patients. Stroke with COVID-19. One of the early studies published at University of Emory, Georgia. It is a retrospective study that has been done on 396 patients who were admitted over a period of 4 months from March to July 2020. And they found 13 patients of them had the confirmed COVID-19. Sorry, 396 patients were admitted with stroke, and they found 13 patients confirmed with the COVID-19. So the results of this study, they found some interesting findings. All the 13 patients had embolic looking strokes. They were able to identify atrial fibrillation as the cause or the possible cause for 4 patients. But in 9 patients, they were not able to identify any underlying etiology, and they classified those patients to be cryptogenic strokes. Interestingly, the 9 patients had an increase in the D-dimers levels, at least more than 3,000, and 4 patients of them had a higher level of D-dimers, more than 60,000. And in those patients, they don't only develop strokes, but only develop other types of hypercoagulopathy, including DVTs and pulmonary embolisms. So some of the potential causes of the strokes, according to this study, they say that it's a multifactorial. Platelet activation and aggregation is a possible underlying mechanism, as the ACE2 receptor has been proved to be present on the surface of platelets. Vasculitis, as we discussed earlier, could be a potential cause. Arrhythmia, hypercoagulability, as like the strokes usually happen in young patients without underlying risk factors for strokes. The embolic looking strokes on the images the presence of other coagulopathy, PEs, and DVTs, and the elevation in the inflammatory markers. Another meta-analysis has been done to associate the stroke with the COVID-19. It is a very large study including more than 65,000 patients. It has been done through extensive literature review through Medline and Embrace. And mainly this study has been done on 14 other studies, mainly to identify the incidence of ischemic stroke in patients with COVID-19. And as we see here, the highest incidence rate was reported to be 4.6, but in this study, only 219 patients have been enrolled. But if we look at the larger studies here that include more than 10,000 patients, the incidence decreases to 0.7 to 1.1. Same thing for the hemorrhagic stroke. The highest study was reported to be 0.9, but larger studies with more than 10,000 showed the incidence to be lower than that, 0.1 to 0.2. Results of this study, they state that the risk of the stroke was small, but not negligible. Higher incidence of cryptogenic strokes, younger patients without risk factors presenting with large vessel occlusions, and some of them even multifocal large vessel occlusions. Interestingly, they found that the lacunar infarction has been decreased by more than 10% during the pandemic. And one rationale behind that is that the possibility that patients with a lacunar stroke, they tend to have minor symptoms and they probably want to stay at home due to fear from contracting COVID-19 if they go to the hospitals. So this is a case report with COVID-19 and stroke. I just wanted to discuss this case just to give an idea on how the stroke could present with the COVID-19 or during the course of the COVID infection. So this is an 83-year-old patient who presented with altered mental status and seizure-like activity. The initial images, as we see here on image A and B, showed embolic-looking strokes on different vascular territory on the right MCA and PCA territory. This patient had to be intubated due to respiratory failure thought to be secondary to aspiration pneumonia. Then he was admitted to the ICU. Then after 1 month, they were able to wean off the ventilation on the patient, but unfortunately, his neurological examination did not improve, so they had to repeat another MRI 1 month later, and this time they found new strokes on the left side of the brain on the MCA ACA territory, as we see here. So that gives us an idea on how the patients not only hypercoagulable at the initial, but could also remain hypercoagulable during the course of the infection. Intracranial bleed with the COVID-19. Several case reports has been reported with different types of bleeding, including subarachnoid, subdural, intraparenchymal, and intraventricular bleeding. One retrospective studies of 5 patients, they states that usually the ICH happen in younger than expected patients, and they usually tend to have a large lobar ICH. Another bigger study has been done to associate the intracranial hemorrhage with the COVID-19. It's done through literature review, and it's included 23 studies, 12 cohort, 6 case series, and 5 case reports. And they found that the average incidence of the intracranial hemorrhage tend to be 0.7%. The most common type is the intraparenchymal hemorrhage in up to 62.6 patients. 9.5% of the patients had the hemorrhage in multiple cranial compartments, and 50% of the patients in this study they were on anticoagulation before the happening of the intracranial hemorrhage, either for prophylaxis or treatment of DVTs or pulmonary embolisms. Venous thrombosis with the COVID-19, not only pulmonary embolism, DVTs, and embolic stroke, as we discussed earlier, but even venous sinus thrombosis have been reported with the COVID-19. They tend to happen in severely ill patients and those who were admitted to the intensive care unit. And sometimes they can happen even if the patient on anticoagulation treatment. And here is one case report on a 59-year-old woman who presented with thunderclap headache. Neural examination showed a bilateral papilledema, and we can see here on the image B, there is absence of the decrease the signal on the transverse and sigmoid sinus on the left side. And on image C, we can see the severity of the infection with the COVID-19 causing infiltration on the CT chest. CNS demyelination with the COVID-19, multiple case reports has shown the association of CNS demyelination with the COVID infection, including ADEM and transverse myelitis. Interestingly, with the investigation of those patients, the CSF did not show the virus, and that make the possibility of the damage could be related to delayed immune response. So they proposed two mechanisms for the possibility of CNS demyelination, either by the cytokines storm or due to antibody production against the glial cells, which could be a para-infectious or post-infectious phenomena. So now we talked about the central nervous system involvement, and I will talk about the peripheral nervous system symptoms with the COVID-19. And as I mentioned earlier, the most commonly reported symptoms are the anosmia, ageusia, Guillain-Barré syndrome, and nerve pain. This is a meta-analysis study done on 10 studies to identify the incidence of olfactory and taste dysfunction with the COVID-19. And as we see here, the incidence has been ranging from 5 in one study to more than 98% in another study. So the average occurrence of the olfactory dysfunction tend to be 52.7%. And same thing for the gustatory dysfunction, very similar to the olfactory dysfunction, ranging from 5 to more than 95%. And the average is 43.93%. It is a time course for the occurrence of olfactory and taste dysfunction during the course of the COVID-19 infection, and the blue bold line represent the smell and the orange line represent the taste. And we can see here the occurrence of the peak of the smell dysfunction tend to happen a couple days prior to the taste dysfunction. then they start to decrease and usually disappear by day 20. Peripheral neuropathy as a complication with COVID-19. The first case report of GBS was reported on April 13 for a 57 years old male who presented with a flaccid symmetric motor and sensory neuropathy. His symptoms started 1 week after the initial COVID symptoms. The patient was treated with IVIG, but despite the treatment, his respiratory function deteriorated, so he had to be intubated and admitted to the ICU. Then on follow-up on this patient, his motor symptoms did not improve after 1 month. A few days later, a study of case series was reported in northern Italy. For this study, it is a retrospective study done on patients who were admitted from February 28 to March 22nd over a period of 3 weeks. Over 1,200 patients were admitted with COVID-19 during this period in 3 hospitals, and 5 of them had the GBS. So they state that the incidence of the GBS tend to be higher than the incidence of this rare disease, which is expected to be 1.6 per 100,000 people per year. On this slide, I'm showing you the characteristics of those 5 patients. Usually the symptoms happen 5 to 10 days from the initial COVID-19 symptoms. Most of the patients, they develop severe weakness, either tetraplegia or diplegia, and 1 patient had facial diplegia and ataxic and sensory ataxia. The CSF findings showed the characteristic findings with the GBS, with increasing the protein and load cells. 1 patient at the beginning, the CSF showed normal protein, but then after repeating another spinal tap, after 10 days, the protein were elevated. MRI usually showed the typical enhancement of the coda equina and nerve roots. And the outcome here after 1 month, despite treating the patients with at least 2 cycles of IVIG, and 1 patient also received a plasma exchange, unfortunately the symptoms, the motor symptoms, did not improve, and the diagnosis of the GBS is no longer being the right answer, and so they developed either subacute or CIDP. Another complication with the COVID-19 is the nerve pain. And on the Wuhan study of the 214 patients, they were able to find 5 patients complaining of nerve pain. And those 5 patients, 4 of them had the severe disease, and 1 of them had the non-severe disease, which makes us think that this complication also tends to happen in patients with severe COVID-19 infection. So for the GBS, since the start of the COVID-19 vaccinations, there was a concern raised regarding the COVID-19 association with GBS. But this information it's up to date from the GBS CIDB Foundation, and they found that there is no such correlation with the vaccine to cause GBS, and even those who had the GBS in the past, there's no reason not to get the vaccine. So we talked about the neurological symptoms and complications during the acute viral infection. But we don't know what's the long-term complications with the COVID-19 infection, until this recently published study that was published last month showed some potential complications as a long-term. It is a very large study including more than 236,000 patients diagnosed with COVID-19, and it's a retrospective cohort and time to event analysis comparing patients with the developing neurological complications and patients with COVID-19 in comparison to other patients who had either influenza or other types of respiratory tract infection. On this table, the first column showing some of the neurological complications that happened, including intracranial hemorrhage, stroke, Parkinson, GBS, nerve disease, neuromuscular disease, dementia, and psychiatric issues. Then here on the second column we are comparing COVID-19 to influenza, and on the third we are comparing COVID-19 to the other respiratory tract infection. And we can clearly see that the patients with the COVID-19 had higher chance of developing those complications, and this is true for almost all the neurological complications, and they are statistically significant. For the Parkinson and the GBS comparison of COVID-19 with the flu, it was not statistically significant with the flu, but it was statistically significant when comparing COVID-19 with other respiratory tract infection. Another way of looking at on this study is by looking at these figures. Each figure here represents a long-term complication. And we have the red line here representing patients with the COVID-19 and the blue line representing patients with other respiratory tract infection. And we can see here that patients with the COVID-19 had a higher chance of developing neurological complications after 180 days, including ischemic stroke, nerve disease, neuromuscular dementia, and psychiatric issues, as I mentioned earlier. On this table, they were comparing the happening of the same neurological complications, but this time, depending on the severity of the COVID infection. So they classified the patient as if the disease were mild and the patient did not have to be hospitalized, versus patient who has been hospitalized or admitted to the ICU, or patient who developed altered mental status. And we can clearly see that the more severe the disease, the more chance of developing neurological complications. And this is true for all the complications as shown here. And this slide also showing the same data but in a different way. So the red line here representing patients with COVID-19 who had altered mental status. The red dotted line represents patients with COVID-19 who did not have the altered mental status. And the bold blue line represents patients with the COVID-19 who were hospitalized, while the blue dotted line represents patients with COVID-19 without hospitalization. And we can clearly see the difference in the neurological complications very clearly significant here on almost all the complications. So the conclusions of my presentation is that COVID-19 infection does increase the risk of neurological complications. Neurological complications tend to happen in severely ill patients, and there are multiple mechanisms have been proposed to cause those complications, but we still don't know exactly what's happening, and further studies needed to prove that. Probably we need like a prospective study to follow up on patients with COVID-19 and see compare them to control patients and see if there is difference in the occurrence of the symptoms. Thank you. Any questions?
Dr. Khaleefah, this is Martin Brown. That was a great talk. Thanks for the review again for the COVID, neurologic effects of COVID. Can you, or did you come across anything about any neurologic conditions that are not monophasic? Guillain-Barré is, it's done. It comes and goes. It does its damage. It may not get better. The ones that you mentioned something about CIDP, but Guillain-Barré that doesn't get better is not. We don't call it CIDP. It's probably an AMAN, axonal, maybe permanent, possibly permanent. But have you come across any reports of things that are like a relapsing remitting or a progressive or an ongoing disease rather than something that comes, the damage is done like stroke and then there's recovery?
Thank you, Dr. Brown. That's a very good question. Unfortunately, I was not able to find such things on my search. And most of the complications, Dr. Brown, we still there are some theories of how they can happen, but we still don't have the proof.
I just think that as the pandemic kind of winds down, I think we'll still be getting patients coming to us for new problems that might be related to COVID infection in November, and they're having new problems in March or May, and we're being asked if these are COVID related.
Yeah.
So it's just that's all. Thanks.
Yeah, no problem. Yesterday I saw my patient. I follow her for a headache, for a migraine headache, and she got COVID-19 in November, and she states that she developed a new type of headache. She says it's pressure-like, it's like exploding my head, and it's completely different than her migraine headache. But it's got better over time. It's got better. So I don't know if that's answer your question.
This is Joseph Niemeyer.
That sounds actually doesn't make sense. That a new headache with the virus that comes and but it shouldn't start in March or May. It should have occurred with the infection during that month or so of the infection.
Yeah, she had it with the infection, Dr. Brown, but after a while it's got better. So when she came to me yesterday, her headache was much better than when it started.
Great. Thanks.
Yep.
I wonder a little bit if any conclusions can be drawn just based on the type of virus. And my presumption has always been that the viruses that cause chronic disease are more typically DNA viruses rather than RNA viruses. I'm trying to think of examples where that's not the case, or retroviruses, for example. Do you have any thoughts about that? That because of the mechanism of this being a coronavirus, it is perhaps less likely to chronically integrate into the nervous system?
I have no idea, doctor, and they still don't know the exact mechanism of the headache with the coronavirus.
Sure.
There are some theories. I think we need more studies to define exactly what's going on. Probably it's like a multifactorial things, because they found that some patients they have meningitis, some patients the CSF was normal, so we still don't have the enough data to answer most of the questions.
Yeah, I think that's right. I mean, the acute presentations are certainly striking. We've seen one patient at least here, and probably a couple, with a very large hemorrhagic stroke secondary to a severe coronavirus infection. And in a young person, it was a very striking presentation, so it can be frightening.
Yeah.
I'm curious, is anything known about the different variants? So do have different variants demonstrated a higher incidence of stroke or vascular disease?
I have no idea. They did not like classify exactly they just like talked in general for the coronaviruses, but I mean you are definitely right. There are multiple like now multiple strains of the virus and could cause different symptoms as what's happening right now in India or you know.
Thank you for a great presentation. It was very thorough.
Thank you. Any other questions?
Just a comment here, Carrie Rimmel. I just noticed that many of the patients I follow complain of overwhelming fatigue, and that I just thought that was interesting, that they never had that problem before they had COVID.
Interesting. Yes, Dr. Ramel. So, I mean, it's a growing. I mean, this study, the one that has been that I just discussed, I mean, if this is real, then we are in a really bad situation. I think we need further studies to provide more data, especially like a prospective study to follow up on patients with COVID-19 and see what they develop, because if this is real, then that will be really dangerous.
Yeah, I agree. We need the prospective studies. UofL is active in following COVID patients, Dr. Ramirez group. So hopefully we'll have some information in their prospective studies.
Yeah.
Hi, Dr. Khaleefah.
Yep.
I'm Hannah. I'm incoming PGR1. Thank you for your lecture. I wanted to know, based on your experience, because we also worked at a migraine clinic and a headache clinic, and there are some patients who presented just like you said with your patient. They had the migraines after COVID, some during COVID. Do you think that they benefited from a certain type of headache medication compared to like the regular migraines that we get? Thank you.
That's a very good question. Yesterday, I asked my patient if, like, I prescribed Maxalt to her for the migraine, and she said it was not helping when she had the headache. The good news that the headache improved after time, so it's not like persistent like the migraine, but unfortunately the migraine medication was not helping with that.
Okay, thank you.
Yeah. Okay, if no more questions, then I will end up my talk. Thank you so much.
Thank you.